Hi, everyone. It's me, Dr. Naveen Pemmaraju, Associate Professor of Leukemia from MD Anderson. And I'm really happy to join my friends and colleagues with the IACH to present to you myeloproliferative neoplasms as we start the new year and just after the ASH meetings in the United States in December. I am an active clinical trialist, as you all know, and so here are my disclosures. And so I'd like to begin with our focus on the MPNs now with 2023 upon us to show you really a promising, even I would describe an exciting array of clinical trials. These are just a sample. We won't be able to focus on all of them, but to give you some idea of the depth and breadth of what's going on. In polycythemia vera, where really there was no novel drug discovery or movement for 3 decades, we now have several programs active. The Ruxo Peg interferon was just FDA approved in the last few years, on the strength of trials conducted exclusively in Europe, and that's now available in the United States for prescription. There's a promising agent that I'm a part of, PTG300, now known as rusfertide, a hepcidin mimetic. And in ET now there's some movement as well, both with the interferon products and novel agents such as LSD1 inhibitors. In the rare MPNs, the ultra-rare diseases such as systemic mastocytosis, a number of drugs being actively investigated, including KIT inhibitors, so KIT-specific inhibitors, improving on the experience potentially from avapritinib and midostaurin, the 2 approved drugs. Furthermore, in the rarest of the rare diseases, such as the 8p11 FGFR syndrome, there was a recent drug approval known as pemigatinib, led by Serge Versovsek with phase 2 data for this FGFR1 drug and clinical trial experience. The bulk of what we'll talk about here, of course, will be in myelofibrosis, which has an explosion of good research. Really 4 categories that I can identify for you out there. One is that of novel JAK inhibitors beyond the approved agents. So we previously only had ruxolitinib and fedratinib. In the past year, we had the 3rd agent, pacritinib, approved, and I'll show you some new data from ASH here in this presentation. And then we all await momelotinib as potentially the 4th drug for JAK inhibitors, should it be approved, and we hope to hear about that later this year of 2023. The second category is that of novel JAK inhibitor combos, so putting on a second drug with the JAK inhibitor, usually ruxolitinib as the backbone to start out. And there are a number of these 3 specifically listed here that are the furthest along in randomized phase 3 frontline, but a number of other drugs now in the field. A third category is completely novel agents that stand alone beyond JAK inhibitor. And then finally, I think very exciting, and we should be including in all of our discussions, is the anemia of MF, some specific new drugs, new mechanisms, new targets, including this ACVR1, which we'll talk about here. So let's begin. I think a good background is this, which is to remember in the United States, we do have some guidelines, some guidance for community and local providers, and one of those main ones is the NCCN. In general, when we focus on myelofibrosis here as we go into the new year, let's keep thinking about it in terms of lower risk, high risk. There is a subset of patients who can be low risk, asymptomatic, survival measured in decades that can go for observation or one of the early intervention clinical trials. Of course, if a patient is low risk but has some high risk features, symptomatic, molecular findings, clinical trial, of course, versus other kind of therapy approaches. And of course, in the high-risk patients, always thinking about allogeneic stem cell transplant as the only curative modality that we still have. And then, of course, the JAK inhibitors, monotherapy is standard, and of course, the clinical trials with combinations, and then all the novel agents that we'll look over. I think as we think about the JAK inhibitors coming out of ASH 2022 and into January 2023, again, we really want to think about this as a class of 3 and now hopefully a 4th drug coming soon. Reminder, the ruxolitinib hits JAK1 and JAK2. It's not a mutant-specific agent, so that means you can be JAK wild type and it still has the ability to work in the patient. Fedratinib is more of a JAK2-specific agent. Pacritinib, not only JAK2, but also hits these other targets, including FLT3, IRAK1, and CSF1R. And then the momelotinib agent, again, a little bit different in that it hits both JAK1 and 2 in this new pathway called ACVR1, which is thought to be part of the reason for the anemia improvement. And then, of course, each of these has their own host of different side effects, which are fairly well known in the field. So let's get to the new data. So this is all from the ASH meeting, December 2022. I think the biggest focus is that of momelotinib, the potential 4th JAK inhibitor in the field, which inhibits, as we mentioned, both JAK1 and 2, and then this new pathway for most of us, ACVR1, which likely is why there's the improvement in the anemia. This reminds us that not all JAK inhibitors are equal. It's good to have options and choices. And likely in the setting of the other targets beyond JAK, you see some of the improved benefits, but also maybe some of the side effects. And so this ACVR1 story is going to be important in this talk as we move forward in the field. Likely the story here is that chronic inflammation also drives a hyperactivation of this pathway, ACVR1, leading to elevated hepcidin, dysregulated iron metabolism, and ultimately anemia in patients with myelofibrosis. And this agent aims to reverse that. And in fact, of course, as we've seen in the clinical trials, many patients gaining improvement in anemia, even transfusion independence. And so the phase 3 randomized trial is that of Momentum, which is momelotinib versus danazol in patients with previously treated JAK inhibitor who are symptomatic and anemic. Almost 200 patients were randomized in a 2-to-1 fashion with momelotinib versus danazol, with early crossover if confirmed progression was available to momelotinib 200 daily. And of course, interestingly here, the anemia signal is one of the important endpoints. And so in this ongoing data set with recent updates from ASH, we see that the momelotinib versus danazol experience is clearly showing a benefit of the momelotinib in terms of transfusion independence at week 24, including looking at mean hemoglobin over time, decreased transfusions compared to that of danazol. And then furthermore, overall survival was found to actually be improved in patients who were able to attain the week 24 transfusion independence mark on momelotinib. And that's even including those randomized to the danazol and crossed over to momelotinib. So that's a very nice new finding. And then, of course, improved overall survival was also shown in momelotinib-treated patients with baseline thrombocytopenia. And that's important because thrombocytopenia is known to be an independent poor prognosis risk factor for our patients with myelofibrosis. And so transitioning to the other JAK inhibitor that's been recently investigated, that of pacritinib, one of the brand new findings of the past year is that pacritinib also is a potent ACVR1 inhibitor. And so that means that there's potential there for anemia benefit in patients with MF. And essentially this data just reminded us that pacritinib is already approved in the setting of cytopenic myelofibrosis, specifically thrombocytopenia, platelets less than 50, so high-risk group of patients. The drug is able to be given at full approved dose, which is 200 milligrams BID, regardless of these cytopenias, and that there was already an anemia signal improvement in terms of hemoglobin in the earlier pacritinib studies, including PERSIST-2, but the mechanism and the extent of the anemia benefit had not yet been fully described. So this finding that the pacritinib agent also inhibits ACVR1 was a very new finding, sort of hot off the press breaking news, and possibly explains the clinical improvements in hemoglobin of this novel agent. Furthermore, laboratory studies were conducted with the pacritinib team showing that not only it's a potent ACVR1 inhibitor, but perhaps several times more potent than even the momelotinib, which was initially shown to have activity against ACVR1. So I think the concept here is that in cytopenic myelofibrosis, anemia, thrombocytopenia, we hopefully now have a couple of agents that we will have available or already do have available to help in those patient populations. And so as we turn to the remainder of the talk, it begins to allow us to dream and think about that of disease modification in our patients with MPNs, not only in myelofibrosis, but also even in PV and ET, the earlier stages. And the concept of disease modification is new, evolving. We have now new drugs, combinations beyond JAK inhibitor monotherapy. And so our group sought to try to define this, perhaps putting forward a definition, something that would mean that you are able to intervene at a point in the disease where you're able to reverse not only the spleen and symptom, the traditional clinical factors, but also show a correlation with this in terms of reduction of bone marrow fibrosis, variant allele fraction, maybe even cytokine burden, and ultimately overall survival improvement for the patients, so that these are clinically meaningful biochemical parameters that are correlated with something that matters to our patients. And so in that spirit, we are now investigating combinations to further improve on the success of JAK inhibitor monotherapy with the hopes to one day lead to outright disease modification. So some of those combinations I'm showing you here on the slide. The three furthest along are, of course, inhibition of BCL-XL with the navitoclax agent, Pi3K inhibitor with parsaclisib, and BET or bromodomain inhibition with pelabresib. And I'll show you the latest data from ASH on those, and then a host of other agents that are now in phase 1 and 2 testing. Also to remind you, there's also a lot of excitement buzzing around novel agents in the MPNs 2022 into 2023 now and beyond. lots of different categories. Some of these include the imetelstat agent, which is telomerase inhibitor, LSD1 inhibition, so on and so forth. And so many of these trials are popping up essentially weekly all across the world. Again, some of them with focus on the anemia of MF. And so let's look at some of these combinations in detail from the ASH meeting. The first one to focus on is that of the BET inhibitor pelabresib CPI 0610 in patients with myelofibrosis. Bromodomain BET is thought to be important in a number of different pathways, including leading to increased cytokine production, aberrant erythroid differentiation, and aberrant megakaryocyte differentiation, and this agent aims to reverse those processes. And so our colleague, Dr. John Mascarenhas, presented the updated pelabresib data, which is combined with Rux for JAK inhibitor treatment naive patients, so upfront myelofibrosis, and this is durability, response, and safety beyond the traditional parameter of week 24. So this is the manifest study, the so-called arm 3 baseline demographics as shown here. This is a total of 84 patients with a mean age of 67 years. And you can see here high-risk molecular mutations in over half, 56% of the patients. In this manifest arm 3 for these 84 patients, you can see the patient disposition here. Essentially, a third of these patients, 35 patients, remain ongoing on the study. And you see here very encouraging results with spleen volume response at week 24 and best reduction. So on the left, spleen volume at week 24 by local review, and on the right, best reduction in spleen volume by local review. And essentially, the summary is that out of these 84 patients, you have an SVR35 at week 24 of 68%. With an SVR at any time increased higher at 80%, so 67 out of 84 patients. This is quite important data. Furthermore, you see in this manifest arm 3 the change in total symptom score at week 24 and best reduction at any time point. Again, on the left is change in the TSS at week 24. On the right is TSS best reduction at any time point. And again, the suggestion is if you go beyond the week 24, so 56% to any time up to 83%, that there are responses beyond or delayed from the week 24 traditional 6-month time point. What about biochemical changes and disease modification? Shown here is change in the bone marrow fibrosis at grade, of any grade at week 24. And you can see here that a quarter of the patients did show 1 or higher grade improvement in their fibrosis by week 24. And this improvement was maintained in half of these patients, which is quite interesting. Additionally, 40% of patients had a grade 1 or higher improvement at any time in their fibrosis scoring. And then summary of adverse events for the novel bromodomain inhibitor are shown here. Again, nothing new or unexpected as compared to the earlier reports. You do see that 12 patients, 14% reported these TEAEs that led to pelabresib discontinuation. And again, some of the known side effects are shown here, including thrombocytopenia and GI. Turning now to a second program that I've been directly involved in, which is that of navitoclax or BCL-XL inhibition. The concept is that the cousin pathway BCL2 inhibition has been so successful in myeloid diseases, including AML. However, in myelofibrosis, it appears that the other pathway, BCL-XL, is the one that's more active and in need of inhibition. In vitro preclinical studies have shown that combination of JAK inhibition with BCL-XL inhibition can lead to synergistic and malignant cell death, including overcoming acquired resistance to single-agent JAK inhibition therapy. And so our group set out to define this or investigate this in a multi-cohort phase 2 experience known as the REFINE study. And thus far, we have reported the cohort 1A, which started out as a suboptimal or add-on trial, which is patients already on ruxolitinib, and then you add in the navitoclax in the setting of suboptimal or failing response. And these results were published in the JCO last year. And what we showed essentially in this first group of 30 patients is that overall survival was not yet reached at the median follow-up time of approximately 2 years in this high-risk group of patients. And so these are encouraging results, served as some of the basis to move forward into the frontline setting. And so our colleague, Professor Passamonti from Italy, showed this updated navitoclax ruxolitinib in the frontline untreated setting for patients with myelofibrosis with focus on disease modification. And some of the highlights are shown here. The combo of Rux and navitoclax showed not only preliminary evidence of efficacy, but also safety in this JAK inhibitor naive patient population. It's already well known that in the setting of BCL-XL inhibition, one will get thrombocytopenia. This was again seen with no new safety signals unearthed. Again, no major hemorrhage or bleeding events associated with this. Importantly and interestingly, a third of the patients who achieved an SVR35 also had a reduction in bone marrow fibrosis. And at any time during study treatment, a quarter of the patients achieved 1 or higher grade reduction in bone marrow fibrosis. Furthermore, I think very interestingly and intriguingly, complete resolution of fibrosis was observed in 2 out of 9 patients evaluated, and the median time to bone marrow fibrosis reduction was about 12 weeks. At any time during the study treatment, a third of the patients with SVR35 also achieved grade 1 or higher reduction in bone marrow fibrosis. So these are early results, small group of frontline patients, but there is an ongoing randomized phase 3 trial, Transform 1 and 2, already in progress. Now, in this phase 2 frontline experience, VAF reduction of 50% or more for driver gene mutations was observed in about 18% of the evaluable patients, and molecular responses were seen as early as week 12. Half the patients had a greater than or equal to 20% reduction in the VAF for their JAK2 V617F allele burden. And there were no major differences in greater than or equal to 20% VAF reductions from baseline to week 12 or 24 between those with or without high-risk molecular mutations. And so the navitoclax plus ruxolitinib program continues in an ongoing 2 randomized phase 3s, one in the frontline Transform 1 and one in the second line and beyond Transform 2 study. And the pelabresib, as I mentioned earlier, is also in randomized phase 3 upfront trials. Yet another program, which is a little bit earlier on in development, is that of inhibition of XPO1 by the novel agent selinexor, which is actually approved in patients with multiple myeloma at higher doses. So this agent was combined with ruxolitinib in this early study. And some of the key criteria here, it's an oral weekly drug, the selinexor agent, still early on. You have 2 dosing cohorts, 60 milligrams PO weekly and 40 milligrams PO weekly. 10 patients thus far had discontinued treatment, as shown here. The concept is that even though it's early on, this is SVR35 and TSS50 at week 24, so the traditional endpoints early, but already showing very impressive 92% SVR35 and 67% in TSS50, and so we await further results and more patients for further evaluation. Here's the waterfall plot of the spleen volume reduction at 24 weeks. Essentially, all patients had some form of reduction in the spleen volume relative to baseline by week 24. One of the concepts with this agent, as with many novel agents, is looking at the treatment emergent adverse events. It's already well known to have some GI toxicity and other toxicities in the myeloma and lymphoma setting at the higher doses. So here in the MF setting, it is a lower dose. The expected TAEs did occur, including nausea and some GI. 2 cases of grade 4 thrombocytopenia were experienced in the 60 milligram dose level. And so again, just with any novel agents, we'll continue to monitor long-term for safety and toxicity. Yet another program that was discussed at ASH was the Ruxo Peg, which is the final results of this phase 1/2 study, ruxolitinib with pegylated interferon alpha 2A, which was presented by our colleague, Professor Jean-Jacques Kalajian from France. This is interesting as it takes 2 of the older available agents in the field, that of JAK inhibitor and interferon, and combines them in an adaptive Bayesian phase 1 setting, which really was focusing really on the occurrence of DLTs, given the concern for toxicity, including overlapping toxicity of this combination. And in the phase 2, randomization between the 2 best dose combinations from phase 1 was performed with the endpoint here of the occurrence of at least 50% reduction in spleen length as measured by palpation. And so, as you can see here, very encouraging results, spleen responses, including the 50% reduction by palpation, which is thought to be equivalent to SVR35 by imaging. From the primary endpoint at week 24, you can see phase 1 and phase 2, the success rate of 67% and 74% here. And then for secondary endpoints, again, a high success rate of 67 and 84% for the combination. I think also very intriguingly is that of VAF, and you do see molecular responses in the JAK2 mutated patients, so-called good responding patients, and the molecular response according to clonal architecture, as shown here. I think what's really outstanding about this trial is the built-in clonal detection defined through next generation sequencing analysis, single cell DNA tapestry analysis to help us really understand at the molecular level the disease modification aspect. Yet another combination study is that of parsaclisib, as we mentioned, the Pi3K Inhibitor. This has been led by our colleague, Dr. Abdul Rahim Yaqub out of Kansas. And this ASH presentation focused on the efficacy and safety of the add-on approach of the PI3 kinase inhibitor parsaclisib to Rux in patients with MF with suboptimal response to Rux. And this is the final results of this phase 2 study. As you can see here, the combination did yield a percentage change in spleen volume and response categories, both early on at week 12 and then the traditional endpoint of week 24. There were favorable changes in the MPN SAF, so total symptom response at the early and the 24-week time point. And then side effects as shown here. This is focusing on the hematologic. On the left, you'll see platelet levels. Overall, thrombocytopenia platelet levels remain steady during this course. And on the right, you'll see hemoglobin levels, which again were thought to have remained overall steady. So making the point that there was not a whole lot of drug-induced thrombocytopenia or anemia that resulted in major changes in the study administration. Most common non-hematologic side effects are shown here. Again, this emphasis on looking at side effects, particularly in these novel agents, either alone or when they're added to JAK inhibitor. And you can see the serious events occurring in 2 or more patients overall as shown here: pneumonia, balls, pyrexia, and then the fatal treatment emergent adverse events were reported in 6 patients, but none were assessed as drug-related by the investigator, again as shown here. So I think as we pause to step back and think about all of these drug combinations, what does it mean? What does it mean for our patients? What does it mean for you out there in the United States and around the world, specifically in Europe, Asia, Africa, South America, Australia, all throughout the world, ex-US especially, as some of these drugs may not be available for quite some time or may represent cost or toxicity issues. I think one of the themes I'd like to leave you with in this talk is the newfound focus on disease modification myelofibrosis and in MPNs in general. The concept here is that not only to introduce all of these alphabet soup of novel agents and drugs, but can we either combine them smartly with JAK inhibitors, or if they're being used as a standalone agent, can they show an improvement in overall survival, particularly in the relapse setting, when we know that after JAK inhibitor frontline failure, especially in the setting of clonal evolution or other progressive factors, that overall survival can be less than 2 years in many of our patients. And so many of our groups are starting to write articles, opinion pieces, editorials, trying to really aim at defining what does disease modification mean? Is it ready for prime time? Can we replicate it? Can we agree on these definitions? And this field is just starting. And I think it's made possible because of all these novel agents and combinations. So in summary, what I'd like to leave you with is to show you the future now coming out of ASH, which is a bevy of phase 3 trials in our MPN field. So as we look at these categories, if you look at after JAK inhibitor ruxolitinib, you have the imetelstat telomerase, which is already in an ongoing phase 3 trial in the relapse setting after JAK inhibitor. And we praise this design because it is focusing on overall survival as the primary endpoint, marking the first time in our field where that's happened. And also the imetelstat is being investigated for activity in myelodysplastic syndrome to add to its repertoire. The momelotinib agent, as I mentioned to you, the Momentum phase 3 trial, randomized against danazol. We have the top-line results positive. We're now awaiting the final analysis and to see if this agent may have potential for approval in the United States and Europe in the coming years. And then the MDM2 inhibitor program, which is now also entered into phase 3 trials, again, in the relapse refractory setting against best available therapy. So really encouraging, nice, novel agents there. If that weren't enough, then we have some of these other add-on concepts. We have the active agent luspatercept, which is already approved in a subset of MDS and is now being actively investigated as a standalone or as an adjunct to JAK inhibitor in myelofibrosis for transfusion independence, anemia improvement. The navitoclax and the parsaclisib agents, as we mentioned, not only as add-on agents, but also as frontline combination partners, very exciting. And then, of course, a host of these agents have now made it in the front line, including into randomized phase 3 trials for the pelabresib, navitoclax, parsaclisib, in particular global international efforts. And then some of the JAK inhibitors are still being actively tested in phase 3 testing as well. And so the future, I would like to leave you with one last abstract for your consideration. This was really a lot of buzz at ASH, and this is the novel discovery of a new agent the INCA 033989 from Incyte, which is a new monoclonal antibody that selectively antagonizes mutant calreticulin oncogenic function in MPN. So this is the first in class of such a drug. A very nice presentation at the plenary and late breaker sessions at ASH. And so this agent, the INCA 033989, is a mutant CALR-specific monoclonal antibody. So that's already interesting and new for our field. Fully human IgG1, Fc silent, and it has selective binding to the mutant CALR, and it antagonizes the mutant CALR-induced signaling and oncogenic function. Essentially, this is our first in class CALR mutant-specific agent. This agent was also found in preclinical in vitro studies to selectively inhibit cell proliferation and induce death of mutant CALR cells, as shown here. And then finally, this agent appears to have the ability for restoration of hematologic molecular responses in a mouse model of ET, and maybe even restore impaired megakaryopoiesis. And so I think the take-home point out of this novel discovery is to track it closely and to hopefully see this in clinic as a first-in-human phase 1 study, which was announced at the end of the presentation that this was in the works. So hopefully in the next year or two, we will see this agent being actively investigated in clinical trials in our field. And so with that, I'd like to thank all of you out there. I'd like to thank our MPN community, particularly my own mentors, colleagues, fellow experts in the field, and to remind you that we have so many chances now to meet both online and in-person meetings, and of course to engage one another in discourse on social media and across other internet-based platforms. And so I leave you with this, that if you have a rare disease or a rare blood cancer, such as an MPN, that you should know that there are so many people out there who are only focusing just on those rare diseases, and that there are new and improved ways of connecting and communicating all of us together for the best hope and the best goodwill for our patients and their families. Thank you so much, and happy to take any questions.
Well, hi, everybody. It's me, Dr. Naveen Pemmaraju. Really honored and happy to be here with the IACH team and all of you out there. So I saw the lively Q&A coming in, and so I'd like to get right into that. You're welcome to type in your question and to interact with me. I think this is a really wonderful format, and really I'd like to thank the supremely amazing Professor Mohammed Modi, Professor Arnon Nagler, the IACH teams for this. So let's get into this. So I'm already looking at the chat box. It's really going wonderfully. The first question, of course, that's on many of your minds is that of momelotinib. And so that's the first question here. And the question, of course, is momelotinib representing potentially the fourth JAK inhibitor. It still needs to be evaluated for FDA approval. And in patients with MF and anemia, what are your thoughts about momelotinib, pacritinib, as they both hit ACVR1 and the relationship of all that? So I think that's important. So the three things I would like to leave you with on momelotinib. One is, can you believe it, right here, breaking news as we're doing this, the Lancet publication just came out a few days ago. This was led by our dear friends and colleagues, Dr. Serge Verstovsek, Dr. Aaron Gerds, and Dr. Ruben Mesa. So that's out. It's available, the full manuscript for the Momentum study. And as we mentioned here, the Momentum study was a randomized phase 3, a 2-to-1 ratio of patients who were already JAK inhibitor exposed. So they had Rux, they're symptomatic anemic, and they go on the study, randomized 2-to-1 momelotinib versus danazol, very importantly, and then crossover was allowed. And as you're already hearing, all of the endpoints were met in this randomized phase 3. So we hope to hear maybe by this summer. And so, yes, as the person in the audience is asking, importantly and amazingly, the mechanism of anemia response is starting to be understood. And that's with ACVR1, this pathway that involves hepcidin and chronic inflammation. I think it's going to be one of the most important pathways in our field as we think about the overall field. And that even includes polycythemia vera, which we'll discuss next on the other side of hepcidin. But the questioner asked very astutely, right? So the other big update at ASH was, as you saw, Dr. Steve O showing that the pacritinib agent, the third JAK inhibitor, actually also inhibits the ACVR1 and potentially even more potently, and that's up to 4 times the potency in the preclinical models. And so what you're asking is very astute and important, that now in this era of cytopenic MF, so patients who present to you or develop low platelets, anemia, either at diagnosis or later on, now we have multiple options. And I think this is very important. Also, not only can the pacritinib agent be delivered, right? Not only can it be delivered in the setting of cytopenias, but now we're actually seeing that it can actually potentially improve the cytopenias, as you're seeing with the momelotinib agent. So what a new era from the first generation of JAK inhibitors, which may have caused or exacerbated, and now these JAK inhibitors improving. So that's a great question. So yeah, that's the take-home point, that pacritinib also inhibits this ACVR1 potentially even more potently. And so you have these two new JAK inhibitors, which can actually potentially ameliorate anemia. So that's a great question. Let's go on to the second question. And it's a nice specific question out there, which we try not to do those in these live Q&As, but this one's a very important one that I would like to share with you. And so one of you out there has diagnosed a patient with PV. And obviously, the question is very interesting. It's a molecular level. The patient does not have a straightforward JAK2 V617F. In fact, the patient has the much more rare JAK2 exon 12. So I'm glad they brought that up. That's a board question. So New England Journal, just a year or two after the JAK2 mutant discovery, which changed our entire landscape, you should also know, both for boards and practice, that there's a very rare JAK2 exon 12 that can occur maybe in 1% to 2% of our patients. That can also be a sine qua non diagnosis of PV. It's important because I get several referrals a year that are to differentiate between our RPV, primary polycythemia vera, and secondary, which is of course much more common. And man, we could miss one of these cases, right? So you either want to reflexively check the JAK2 exon 12, or if you have a strong suspicion of PV and JAK2 V617F negative, please make sure to work with your pathologist to add that. So this patient case has both the JAK2 exon 12 mutation, but also it appears to be a MIPL mutation. So that's extraordinarily rare to have, a MIPL mutation with the JAK2 exon 12. And so I think what's important in your case, you've ruled out CML, BCR-ABL negative. I do think that that's a very rare case. So make sure to work with your pathologist and potentially, if it's possible, to even report this case as a series or a case report in the literature, as we tend to not see those two mutations occur simultaneously in PV. And also think about if the patient may be developing myelofibrosis or MDS, MPN, CMML, something of that nature. So that's a good one. Another good question here is asking about the development of the immunotherapy. Well, this is awesome, guys, about immunotherapy, CARs, BiTEs, dual antibodies, et cetera, in the MPN domain. Excellent question from Dr. Arbab. This is a great place, and all of this is just breaking news, right? So just at ASH in December, which I had the privilege of attending, over 25,000 people there in person. The two breaking stories for you is that, yes, finally, we're starting to see a potential for immunogenic or immunologic modulation in MPNs. The earlier efforts have not been so successful. You can look in the literature. We and others have tested the ipilimumab, nivolumab, the standard CTLA-4, PD-1, to not much success as single agents, particularly in the relapse setting. But the CALR appears to be something that could be a signal. The CALR mutation appears to have neoepitope immune modulation potential. And so, yes, many groups around the world are working on targeting CALR. There's vaccines that are now in the clinic, so peptide vaccines and others. You have the discovery by Insight, nicely presented at the ASH plenary session, on the mutant CALR specific monoclonal antibody. I think I had a few slides here for you. And so that will be coming into phase 1 clinical trials in the next year. And then, yes, for sure, CAR Ts and all these immune therapies that you've seen developed in the more acute leukemias, lymphoma, AML, ALL, CLL, I do suspect that we'll start to see them. I think in our field of MPN, of course, heterogeneous diseases, the lower risk ones, the survival can be measured in decades or normal life expectancy in many patients. So we need to balance out toxicity, obviously finding a rational target, and then obviously across the world, geographic considerations such as cost, access to care, and then if there's prolonged myelosuppression or toxicity, rescue with allogeneic stem cell transplant in advanced myelofibrosis patients. So How about that? If you had asked me the same question a few years ago, I think I would have said, not yet, but the era of investigation, preclinical and phase 1 is starting from that standpoint. Another great question from my dear friend and colleague and one of the main leaders of the IACH program from Israel, Professor Arnon Nagler, asks, a great presentation, any compound drug or combination inhibitors to address the transformation of MF to leukemia? Thank you, Professor Nagler. My goodness, we could not be meeting at a more important time to talk about that question. For many of you out there, if there are patients or patient advocates watching this live Q&A, this is an important area for us. And I think there are 3 important points to look for in this area in 2023. Number 1, unfortunately, historically, when our patients transform from any MPN, but particularly MF to AML, our patients have often not had a very good outlook and prognosis. And this is often measured less than 1 year, less than even 6 months in some studies, particularly in our older patients and those with comorbidities. And one of the reasons is, as we know, is once you have an antecedent hematologic disease, MDS, aplastic anemia, MPN, sometimes it's tougher for the disease to go into remission or to stay into remission, and many patients don't qualify for stem cell transplant because that's the only curative modality. So the historical background is that a lot of our patients have not done so well with conventional chemo and getting to the stem cell transplant. So I would say number 1 is stem cell transplant is the only curative modality that we have so far. So for the young fit patient or even the older fit patient, modifying, we've done some advances with donors, so haploidentical donors, et cetera, stretching out the age of the transplant conditioning regimen. So it should be done at a center of expertise. But I want to emphasize allogeneic transplant is really the only potential cure. Now, number 2 and 3, the exciting areas of research. Number 2 is that of novel pathways that we had either missed before or that were coming up newly. And one of those I would highlight is the BCL-XL, for example. You saw that's one of the ones that I'm part of co-leading, one of the agents, lead agents, navitoclax, in either the chronic setting or the suboptimal setting. But it appears that rather than BCL2, which we're all familiar with, venetoclax, et cetera, which is very important in AML and CLL in rare tumors such as BPDCN, that the BCL-XL pathway may be active in patients with post-MPN AML. And so that's one strategy to look at in combination with other agents for post-MPN AML. So I'm just giving one example of a pathway, obviously many more, bromodomain, for example, et cetera. So looking for novel pathways and applying the drugs that we're doing in the relapsed chronic MF setting and suboptimal for the post-MPN AML. Those are investigations that will need a few years to come. And then finally, Professor Nagler, another strategy is looking for targeted mutations. So maybe it only makes up 5 to 10% of patients, maybe more if we look, but looking for an IDH1 or 2 mutation, for example, FLT3 mutation. We already know from AML that these drugs are FDA approved, they're active, but we also know that almost always, almost exclusively, our patients with post-MPN AML accelerated blast phase are either excluded or not included in many of these trials, and that's even including ones that include post-MDS AML, so for example, the CPX351 development. And so looking for a targeted mutation at the time of the progression, at the time of the relapse, outside of ASX01, TP53, because those are not exactly yet directly targetable, may yield some benefit. Our friend and colleague, Dr. Odeniki, along with Dr. Anand Patel at the University of Chicago, has published a nice paper looking, for example, at IDH mutated post-MPN AML and having some success with the IDH inhibitor in combination with either hypomethylator agent or intensive chemotherapy in that setting. So I would say to review allogeneic stem cell transplant in those who qualify, for the vast majority who don't, looking for novel pathways, clinical trials to enroll to, or looking for targetable gene mutations on a readily available panel that you're able to access. So that's excellent. Another question we have out there, this is a really important one, and it reflects the worldwide audience, and which is why I love to join you guys on IACH programs. This is a question of a very young patient with an MPN who has thalassemia minor, anemia, et cetera, right? And so I think this is an awesome question. This is important. It comes up a lot when you have someone with PV, but the MCV is super low, all of that. And I think there's 2 points that I would make for that, particularly with this worldwide audience. Number one, as unfortunately, as we know, our patients are individuals. Each person is a separate life, a separate soul, and so nobody follows a textbook. Presentations are not cleanly given as on a board exam. And so you're right. You need to look for multiple blood abnormalities in our patients. So I love that question. So first of all, people can have more than one blood cancer, right? As we all know, you can have systemic mastocytosis and CMML. You can have MPN and multiple myeloma. So obviously bone marrow biopsy, I advocate in all these patients. Number two, for these classical heme disorders, you're correct. A lot of these MPNs can track with autoimmune diseases. They can track with hemolytic anemias. The MPN itself can elaborate a hemolytic anemia. Many patients have genetic or non-genetic hemoglobinopathies. Yeah, so I think the point is a good one. I think what I would say in those situations is, if you're a specialist in only cancers or malignant, make sure you're coordinating with the benign or classical now, as we call, hematology team. Remember to alert your pathology lab, as some of these patients may have different antibodies, different blood shapes or sizes. And then you're right, some of our medications can classically cause, right, hydroxyurea, for example, causing a macrocytic anemia. It's actually a great question. And then the other concept is iron overload syndromes in patients who are requiring multiple transfusions in some of our thalassaemic patients. So I think this is important. I think around the world, looking for G6PD deficiency, and other causes for some of these situations are important. And then finally, drug responses. People may have different responses to different drugs worldwide as we roll these out together. So I think that's also important to keep in mind. So excellent. And also reminds us the importance of the peripheral smear, the history, the family history. I think the story behind the story, right, with each patient, and then maybe genetic counseling or other situations that may be helpful. Great. So I'm looking at the chat box here. I think one final point I would say before we sign off is the importance of working together in terms of clinical trials. I'm really pleased to tell you from our MPN community standpoint, even despite pandemic and so many things over the last 3-4 years, not only have we continued to enroll in clinical trials together, but actually global multinational phase 3 randomized studies. The 3 combination studies come to mind, the Rux navitoclax, Rux pelabresib, and Rux parsaclisib, either already enrolling or opening new studies across the world. So thank you to all, and it reminds us that we're all in this together, that if we work together, despite all of the hardships, that if we can enroll patients with these rare diseases, not only can we give new information, but we can also generate new hope together. And that's why I think platforms and venues like this one, IACH, which was already booming prior to the pandemic, have allowed us to communicate to each other through social media, through forums like this. And I've already seen so many of you, I can see from all over the world, you've joined here. So just remember that we're all in this together, whether in person or virtually, that we have the ability to connect now more than ever. And so it should lead to the democratization of information in these rare diseases such as MPNs. Thank you all very much. I believe we're right here at time. I don't see any other questions here, so I'd like to bid you all a farewell. Have a wonderful happy new year of health, prosperity for you, your families, your patients, and their families. Thank you very much all. I'll sign off here. Bye-bye.